Bob Harrington for inviting me to present on this topic. I was very flattered when he asked me earlier this spring. A little bit more about myself. I initially did research in the late 80s and early 90s at Rocky Mountain Labs in Montana, and it was in a lab doing early HIV vaccine research. But for the past couple of decades, I've been a clinician. So this is a very broad topic, and I've tried to narrow to a few areas that I can review, perhaps give you some new information. But I realize I'm speaking to a room full of many people who are experts in some of the areas that I'm going to mention. So please correct me if I've misrepresented your research or your studies or your data. But I want to try to inform also the wide audience of students who may be listening here or watching, as well as public health workers, case managers, and others who are part of the AIDS Clinical Conference. So we'll go ahead and get started. I have no disclosures. Some of the objectives, we'll talk about a few differences between men and women in the biologic response to HIV, talk about antiretrovirals in contraception and pregnancy, and then a little bit about women and men in research, women and the continuum of care, and stigma. A little bit about Kaiser Permanente, largest managed care organization here in the United States, 12 million members. Michael Horberg directs the HIV Interregional Initiative for our Kaiser regions. He tells me we have 27,000 members with HIV, second only to the Veterans Administration in the number of HIV members in an integrated system. And late in 2017, Group Health became Kaiser Permanente Washington and Kaiser's 8th region. We're distinct from Kaiser Northwest, the one in Oregon. At Kaiser here in Washington, we have about 1,000 members with HIV. 97% of our members have suppressed viral load. Only 10% are female. But over 50% are over 50 years old. We have HIV care being done by HIV specialists, infectious disease providers, and then what we have trained a cohort of HIV PCPs. These are primary care providers with 5 to 20 stable patients that are mentored by a specialist. And then we have 800 PrEP patients. We usually start them on PrEP at an office or phone visit. They do quarterly labs. We don't require a provider visit. And we're able to monitor them with registries in our integrated system. We do virtual mentoring and consults. And we partner with HIV and PrEP clinical pharmacists and partner quite closely with our specialty medication pharmacy, which helps the patients with copay assistance, adherence monitoring, lets us know about late refills, insurance changes, other problems. And then Washington's Collaborative Drug Therapy Agreement for pharmacists allows the expanded role for pharmacists. So some of the topics I'm going to talk about: epidemiology, the biologic differences, pregnancy, research, continuum of care, and stigma. So I like to start with epidemiology with my talks, remind you that globally 37 million persons living with HIV, 18 million of whom are female. They're concentrated, as you can see, in sub-Saharan Africa, India, Southeast Asia. If we look at women as a share of people living in these regions, globally, a little over half of women, or half of people with HIV are women. In sub-Saharan Africa, 60%, Caribbean, 50% of the people living with HIV are women. Eastern Europe, Central Asia, 40%, Asia and the Pacific, 35%, Latin America, 34%. And then, as you can see, Middle East, North Africa, less, and then Central Europe, Western Europe, and North America, closer to 20%. Here in the United States, 1.2 million people living with HIV, of which 260,000 women, 40,000 new infections in 2016, 7,500 of those, 19% female. We do see that the HIV incidence among women is decreasing, but we see that women of color are particularly affected, with Black women, 60% of new diagnoses, Latinas, 17%, white women, 20%. And a different way of looking at that, diagnoses in these populations of females, focusing on the Black and African Americans and white. The green bar is the female population in the United States, and the proportion of Black African Americans, 13%. The proportion of diagnoses of new HIV infection, 61% in Black African Americans. It's about equal in Hispanics, and in white women, 63% of the population, but only 20% of new infections. So the disproportionate effect on Black African American women. You can see that the rates of female adults and adolescents living with HIV is centered in the Southeast and up in the Northeast, particularly District of Columbia, New Jersey, New York. Looking at transmission category in diagnoses of new HIV infection. Black African Americans, the purple bar is heterosexual contact. So 92% in Black and African American women, 88% in Hispanic Latinas, and 71% in white women, with 28% of white women new infections attributed to injection drug use. In Washington State, 14,000 people living with HIV, 15% are women, 85% men. We think that more than 90% of people with HIV in Washington have been diagnosed. In 2016, 440 new infections, of which 22% women, 78% men. And for men, it's men who are having sex with men, the predominant mode of transmission. Another way of looking at new HIV case rates by gender, the blue line being females, which has stayed relatively constant, perhaps increasing a little bit. The orange-brown line, males, which has been decreasing, as have our cases each year overall been decreasing. The Department of Health puts out graphics, the new HIV cases in women by race and ethnicity in Washington State. This is 2009 to 2013. The black part of the pie there is white, non-Hispanic women, 33%. The dark gray, Black non-Hispanics, 43%, and Hispanics, 10%. And another way of looking at the rates by race and ethnicity, you can see the quite high rate in Black non-Hispanics at 32%, and the rate in white women much lower at 1%, or excuse me, new HIV cases per 100,000. By risk category, women here in Washington State, heterosexual contact, overwhelmingly 71%, injection drug use, 23%. This is female cases overall. So we're gonna move to biologic differences between women and men in HIV infection. This is a graphic I cut out of a science magazine in the early 90s and have carried it with me ever since. This is a peer educator in Uganda who's saying in 1991, quote, "If they can put a man on the moon, why can't they make something we can use to protect ourselves from HIV?" This was in early 1990s. So factors that can increase a woman's risk of acquiring HIV. The female genital mucosa, particularly in young women, the immature cervix has a larger area, increased expression of HIV co-receptors. Inflammation in the vagina can increase the risks of acquiring HIV. a recent article associating food insecurity and inflammation and risk of HIV. The microbiome, which is affected by bacterial vaginosis and progesterone. I think Dr. Marazzo probably covered this quite thoroughly in her talk earlier this summer. There are hormonal changes during the menstrual cycle, which will affect susceptibility. As women age, vaginal thinning and dryness increase risks. Sexual practices, anal sex, intravaginal soaps, women who use substances that may dry the vagina, all of these increase risks. And an article published just a couple of months ago in Journal Infectious Diseases showing the risk in late pregnancy and postpartum in women who are HIV negative is quite a bit higher than at other times. STDs, particularly ulcerative and inflammatory, syphilis, gonorrhea, trichomonas, increase the risk. I did want to mention that PrEP certainly decreases the risk of acquiring HIV. And PrEP is safe with hormonal contraception. I'll remind you that Truvada does take 20 days, our current thoughts, to reach an effective level in cervicovaginal tissue. And efficacy for on-demand PrEP has only been shown in men, not women. Women are encouraged to take Truvada daily for PrEP. But some of the other factors, risk factors for women, social factors, gender inequity, not knowing whether their partner has HIV or their partner's risk factors. 30% of new infections in women are linked to sex with bisexual men. Women may not understand what HIV is, how it is transmitted, don't know how to prevent it. Women with a history of sexual abuse and or intimate partner violence have been shown to have an increased risk of acquiring HIV. Commercial sex workers, use of illicit drugs, and poverty, particularly exchanging sex for money, drugs, or food, and difficulty refusing unwanted sex. From the beginning of the epidemic, it has been associated with populations that are afflicted with poverty. A reminder about HIV infection in women. Women have different susceptibility, different immunologic response to the different HIV subtypes. Women frequently have a lower viral load than men who have the same CD4 count. However, disease progression is similar in women and men. Viral suppression is thought to be similar once ART is started, but we do know and have suspected that women metabolize ARVs differently and may have different and more side effects. I also was able to find that there are differences in opportunistic infections with less capices, perhaps more Candida esophagitis. We do know about abnormal cervical cytology in women with HIV. It's associated with HPV, lower CD4, higher viral load. Still not certain that ART impacts the natural history of cervical cancer. And although abnormal anal cytology is shown to be common in women, not clear whether we should actually be screening for it. And a note on contraception. I encourage everyone to discuss desires for pregnancy and family planning with all your patients, not just your women patients, your females, but males, transgender females, all your patients. Revisit that topic frequently and remind your patient that undetectable is untransmittable, because that can inform family planning. Reminder that all women should be on antiretrovirals and undetectable prior to conception. That would be the ideal to reduce or almost eliminate vertical transmission to the baby. In preventing pregnancy in women with HIV, any contraceptive method can be used, including the IUDs. However, there are some drug-drug interactions between some contraceptives and some ARVs. Gets a little complicated. It is okay to use Depo-Provera shots with all ARVs. However, efavirenz, some of the protease inhibitors, whether they're boosted or not, I would encourage you to consult an HIV pharmacist. The levels of estrogen can be either boosted or reduced, which might influence how much of or what kind of oral contraceptive you may prescribe. On the other hand, contraceptives do not seem to significantly affect levels of antiretrovirals. And just a note, hormone therapy. Hormone replacement therapy in menopausal women hasn't been studied very much. We think it's probably safe and should be discussed with your menopausal women. Estrogen, same with estrogens for gender-affirming therapy. There may be interactions that hasn't been well studied in the transgender population. I did find a recent small study interviewing trans women about their beliefs and practices around their ARVs and hormones, and the majority of the group that this person interviewed said that they continued to take their hormone replacement rather than take their ARVs because of the concern for interaction. So we don't know a lot about the interactions, but I would encourage you to engage your trans patients, ask them about their beliefs and their adherence to their ARVs. Pregnancy, certainly an important topic. I pulled the article from the New England Journal, November 1994, that changed everything with pregnancy. This was the pediatric AIDS clinical trial group protocol 076 that showed that giving pregnant women AZT, zidovudine, during pregnancy, during labor and delivery, and then to the infant was able to substantially reduce the transmission of HIV. In this simple but rather important telling graph, the women who received placebo, an average of 25% transmission, perinatal transmission of HIV. It actually was anywhere between 10 and 40%. The women who received AZT reduced their transmission to 8%. I don't have the notes on my slide. There was an analysis done a couple of years later when the viral load monitoring was in use, and it showed that transmission was correlated with a higher viral load. The practice of giving AZT during pregnancy actually began to be in use prior to the publishing of this article in 1994. When I was going through the New England Journal archives of HIV articles, it was interesting to see that in 1995, 94, 95, there was a lot of controversy. Should we screen women who are pregnant? Should it be routine screening? But by 1995, it was considered fairly routine, and in 1996, the CDC actually came out and said, do opt-out screening. So adopted rapidly. This also very simple graph, but very significant in the peak of perinatal transmissions in the early 1990s, dropping rapidly and precipitously. The blue line at the bottom is perinatally infected children and adolescents now developing AIDS. Actually, I think it was 99 infants in 2016 born infected with HIV. 60% of those were Black or African American. Some recent concerns about using antiretrovirals in pregnancy, particularly around Dolutegravir. You may know that as Tivicay. It's also in Triumec and Juluca. A possible association with neural tube defects, the critical times being preconception and the first trimester while the neural tube is being formed up to to about 28 days after conception. DHHS is now recommending it's okay to continue dolutegravir if your patient's on it and she's 6 weeks past her last menstrual period. You've missed that critical time. It's also okay to start dolutegravir. In fact, generally recommended if you have a woman who is beginning ARVs, maybe just diagnosed or beginning ARVs more than 6 weeks after her last menstrual period. However, if you have a woman who is considering pregnancy, then using a regimen that does not include dolutegravir or some of these other more recent medications that we just don't have enough data on, tenofovir, alafenamide, cobicistat, Stribil, Genvoya, now Simtuza, and the new Biktarvy. It's thought that Bictegravir, which is in the Biktarvy, is similar to dolutegravir, so don't use it at this time. Here are the articles that came out on it. May 2018, actually these were more statements. Both the FDA, I think on the same day, put out a statement, as well as the World Health Organization, calling attention to these potential safety issues of women using dolutegravir. Apparently this was based on a preliminary unscheduled analysis of an ongoing observational study in Botswana. And what happened was they found 4 cases of neural tube defects out of 426 women who became pregnant while taking the dolutegravir. And that rate of 0.9% was compared to 0.1% in infants born to women taking other ARVs. This was May 2018, and pretty rapidly we all became aware of that. And then in July, a comparative study, this is in Lancet Global Health, of dolutegravir-based regimens versus efavirenz-based regimens started during pregnancy in Botswana. They were able to begin this study because in 2016, Botswana changed its first-line antiretroviral therapy from an efavirenz-based therapy to dolutegravir. So able to do a comparative study, they found no difference between dolutegravir-based versus efavirenz-based. However, they do note that the rate of adverse fetal effects and outcomes and severe adverse outcomes were greater in the women on the efavirenz and dolutegravir-based regimens compared to HIV-negative women. So ARVs in pregnancy, for those of you who've heard for years, don't use a tripla. It's now thought to be okay. Maybe there isn't actually an increased risk of neural tube defects that we believed over many years. So efavirenz, Sestiva, a tripla, now the generic Simfi. You can continue or start darunavir boosted with ritonavir. However, the dosing changes. It needs to be twice a day. Women who might still take Kaletra, the dosing also needs to be increased due to drug distribution that changes when women are pregnant. And I would encourage you, DHHS has perinatal guidelines that are quite comprehensive, as well as the Antiretroviral Pregnancy Registry. Don't know if you've tried enrolling someone in that. It's not simple, but it is an important registry to gain information, preferably enter a woman before delivery rather than afterwards. And some other basic notes for women in pregnancy as reminders for case managers or other non-clinicians who may be seeing women. They should be having their viral load checked frequently. Undetectable is untransmittable to the baby. Ask about adherence to the antiretrovirals. That's, these are probably the most important things. Women, when they're pregnant, do tend to take their antiretrovirals, even if they've had to change from a single tablet regimen to a twice-a-day raltegravir or other regimen. The U.S. Preventive Services Task Force recommended in 2009 to screen for syphilis as early as possible during pregnancy. Earlier this month, they reaffirmed that recommendation. CDC and the American College of Obstetricians and Gynecologists, ACOG, recommend that if a woman's at increased risk of syphilis, a higher prevalence in their community, if they're living with HIV, incarceration history or incarcerated, or commercial sex worker, consider screening again for syphilis in the 3rd trimester, preferably at 28 weeks, and again at delivery. Should we screen for hepatitis C? Currently, it's a risk-based screening recommendation. Just this month, an article in Clinical Infectious Diseases by a group of hepatologists who recommend universal HCV screening. And their rationale is that women may only be in care when they're pregnant, so it's an opportunity to test for it. It may change the behavior of the woman as well as the practitioner. It gives you a chance to also screen the infant for hepatitis C and get the woman in treatment for hepatitis C after her pregnancy. Breastfeeding in high-resource countries, we continue to recommend against breastfeeding. We don't know, have enough data about whether there may be transmission to the infant. However, and Dr. Levinson covered this earlier this year, Judy, it's a conversation to have with your patient in terms of harm reduction. I do have women who have been from East Africa, very private with their diagnosis of HIV, have not told family, have not told their mother who may be coming to stay with them when they deliver that they're HIV positive. And if the family or their close friends see them not breastfeeding, that becomes a topic for what's going on, why aren't you breastfeeding? So having the discussion about the risks, possible risks and benefits to the woman and the baby. We do recommend that women not pre-masticate or pre-chew food for the infant. So a little bit about clinical trials and research and the inclusion of women. So an article in Journal of AIDS in 2016 looked at clinical trials, vaccine trials, cure research. The clinical trials up at the top, almost 400 trials with 95,000 participants from 1994 to 2011. The average of women increased over that period of time. This is the average from 9% to 22%, but still quite a variable number even now. Vaccine trials, 53 trials were looked at, 33,000 participants, average of 38% female participation, average again. Cure research, they looked at 100 studies with 15,000 participants, and the average in that was 11%. So when women are not in trials, the problem would be underrepresentation in clinical trials can affect how we apply research findings. Pharmacokinetics are going to be different in women and men. That's how drugs are absorbed and distributed in the body. And the treatment response, pharmacodynamics, the effect of the drug on the body, and side effects that women may experience as opposed to men will not be discovered if women are not in the clinical trials. And clinical trials also influence public policy spending on research, treatment, and prevention. In cure trials, underrepresentation, just as an example, women have a smaller reservoir of HIV that can be reactivated. Reactivation is inhibited by estrogen. And so study beginning this year, continuing into next year, what if you add tamoxifen, an estrogen blocker, to vorinostat, a latency reversal agent in women? Will this lead to a cure for women that may actually be different than what we will have for men. The Cornell article concluded that some of the barriers to inclusion of women in trials, the possible effects on unborn children, time commitment, costs of transportation, childcare, other logistical barriers. Women lacked understanding of trials and knowledge about trials. So even when you try to recruit women, you may run into difficulty due to some of these factors. I did look at the recently approved ARVs, Dolutegravir, Intracytobine, Tenofovir, Alafenamide, Biktarvy, and Simtuza, the Dolutegravir, Cobicistat single tablet regimen. Under Biktarvy, the studies in patients naive to antiretrovirals, 10% female, 12% female. In the studies done where patients were switched to Biktarvy, 11% women, 17% women in the second one. Gilead did look at treatment outcomes and said that they were similar across subgroups by age, sex, and race, even with the small numbers. For Simtuza, their naive study, the AMBER study, 12% women. Their switch study, Emerald study, 18%. And I couldn't find any comment by Janssen in their literature on the outcomes by sex. Now, Janssen did try to include increase the inclusion of women by doing the GRACE trial in 2011, gender, race, and clinical experience. This was looking at Dolutegravir, Ritonavir, twice-a-day dosing. They recruited 400 participants, 67% women at various sites, surveyed the women afterwards, positive comments, the study, staff support, education, access to treatment. Negatives were too many blood draws, transportation, side effects. This was Dolutegravir, Ritonavir twice a day. And the women who were non-adherent, the association being a primary caregiver, unemployed, and lacking transportation. And then Gilead 2012 did the Women Antiretroviral Efficacy and Safety Study. They recruited almost 600 women from 80 different sites globally and compared and I'm using, the brand names because it's a lot easier than listing out all the ingredients. Stribild versus Truvada with atazanavir and ritonavir backbone. And when the study was done looking more at women, Stribild was actually significantly more effective and safer than the atazanavir regimen, which was in contrast to the trials that were actually done and used for FDA approval of Stribild. The approval trials showed the regimens to be equivalent, and the thought was not enough women were included in these trials for approval to show that significant difference. Ongoing trial right now, the REPRIEVE trial. This is funded by the NIH. First large-scale study looking at a way to prevent heart disease in persons with HIV using a statin, which has very few interactions with any of the ARVs and may also reduce inflammation. This REPRIEVE trial will also look at how female-specific factors, such as hormones, can affect heart disease risk and risk reduction. A group of mostly women have taken some of the money for the REPRIEVE trial and tried to develop a campaign to empower women with HIV to participate in this trial. They talked with women to try to get a sense for what would encourage you to participate in the trial. And they said, if I talk to another woman who's participating, if my healthcare provider recommended it, I would do it because I have a desire to further my own education and the education of others. and I want to help others, so altruism. This is the graphic they developed to encourage women to at least become aware of the trial, consider joining it. And then the Women's Interagency HIV Study, WHIS, has also looked at reasons why women will stay in a trial. To remind you, this is an ongoing prospective cohort study of the impact and progression of HIV in women that was begun in 1993. Over this period of time, 5,000 women have joined, and 85% have been in it for at least 5 years. They ask that the women come in every 6 months for questionnaires and comprehensive exams. When they ask what kept women engaged in this research, they said assistance with logistical barriers, transportation. If they're spending a whole day traveling and undergoing the exams, providing food, just basics. And then this altruistic and other involvement in the community of women with HIV for support amongst themselves as well. So a systematic way to include women in trials, NIH actually has now published a policy on the inclusion of women and minorities where they say results of clinical trials, phase 3, must analyze the results by sex, gender, race, and/or ethnicity. Looking at NIH funding and research priorities for determining AIDS funding over the period 2016 to 2021, a high priority for research funding is research to reduce health disparities in the incidence of new infections or in treatment outcomes. And also the HIV Vaccine Trials Network, particularly here at Fred Hutch, they are following good participatory practice guidelines, doing community outreach to educate and engage different members of the community, including women. Their community advisory board, including women and minorities, and statements of ethics on their website and in their documents. I was a bit surprised. I initially thought the continuum of care would be quite different, women versus men. It's actually not. When you look at women, men, and the totals, this is the person's living with diagnosed or undiagnosed HIV and their care continuum here in the United States. The dark brown, gray on the left is the diagnosed persons, total on the left, male in the middle, female on the right. The red bar, receipt of care. The stripe bar, retained in care. And then the viral suppression blue bars. So not a big difference there at all between men or women. Still a low rate of viral suppression, as you might note. However, if you break this down by sex, age, and the transmission risk, or transmission by, this was, I didn't do any of the graphics, very complicated tables that the NA Accord cohort has been sorted into, but does find differences in the women, men, and race. It's interesting, in some age groups, Black and Hispanic women are more likely to be in care, suppressed versus whites, and then in other age groups, totally different. So it really needs to be broken down, and we'll see this in the Washington care continuum as well. Overall, our Washington continuum of care is quite impressive, with 71% suppressed viral load, 79% of people who are actually diagnosed have a suppressed viral load. If we look at the female and male portions of that, late diagnosis, that's, remind you, that's being diagnosed with AIDS within 12 months of your HIV diagnosis. Women and men, roughly equivalent there, still a quarter of people diagnosed late with HIV. Women, maybe slightly more increased or slightly higher linkage to care compared to men. Similar engagement in care and similar suppression of viral load. However, breaking that down, looking at King County itself, late diagnoses, a little bit more frequent in women than men. And in 2016, although the total suppressed viral load, 82%, if you look at subgroups, transgender, US-born Blacks, and people who inject drugs, you do see a disparity there. This is not broken down, though, by women and men. And finally, stigma, which is huge for men and women. And I've only listed a few of the causes and effects here. Certainly there are cultural reasons for, excuse me, for women with HIV to be stigmatized that we know about. Many people do not know about HIV and transmission, or still think of HIV and AIDS from the 1980s. STDs in general are still seen in, by many people as a moral failing. One of my female patients, when I asked her to describe some of the challenges she faces and stigma, she said that she frequently feels like women are damaged goods when they have HIV. There's structural reasons for stigma, certainly the criminalization of HIV, commercial sex workers may be less likely to test for HIV, less likely to engage in care. The state statutes, which Larry Strick and others are working to decriminalize here in Washington State, add to the stigma, and certainly are out of date with our current knowledge around HIV. Effects of this stigma in women who have HIV. They may be remaining in a relationship they would otherwise leave. There's a high rate of depression, isolation. I have more than one or two East African female patients who, each time I see them, I ask them, have you told anyone about your HIV? And they say, no. Literally, I'm the only other person who knows they're HIV infected. Isolation, which leads to less engagement in care. There's the fear of disclosure and denial. Just a couple of quick things. This I found very interesting from the Journal of, I don't have the note here, JMIR, Journal of Medical Internet Research, Public Health and Surveillance. This looked at abstracts from the IAC conference over the last 25 years and mined the text for terms and then created some of the data visualization pictures. AIDS epidemic declined in use after 1991 and was replaced by HIV epidemic, and which still increases. We no longer, or they no longer saw carriers or victims of HIV appearing in the abstracts after 2008. The use of HIV positive, HIV infected peaked in the early 1990s. Men who have sex with men and MSM was rarely used until 1994. You may recall before that it was gay and homosexual. And we also see less and less use of the word prostitute, and that's been replaced with sex worker. The conclusion in this article is that less stigmatizing language can facilitate effective communication between health professionals and people affected by HIV. And the World Health Organization recognizes that terminology changes can reduce stigma. And their recommendations use HIV, not AIDS, unless you're referring specifically to an AIDS diagnosis. So you'd say HIV test, not AIDS test, or a person living with HIV. They're at risk of HIV, perhaps an HIV patient. They recommend not continuing to use the term IV drug user, but rather a person who uses IV drugs. The term vertical transmission is actually preferred to mother-to-child transmission. However, the MTCT, mother-to-child transmission, is so pervasive in the literature that may be a little bit more difficult to transition to. But in particular, you never want to say that a woman gave HIV to her baby, which we did used to say, and some people still will accidentally say. And I want to remind you, when you're doing PrEP and coding for PrEP, there's some pretty pejorative terms that can be used. High-risk behavior, high-risk homosexual behavior, risky sexual behavior. I encourage people to use exposure to communicable disease, or perhaps exposure to HIV, risk of HIV, when you're doing your PrEP diagnosis coding. So, final slide, to reduce stigma. We don't know all the ways, but we're trying some. The Department of Health has been convening what they call villages, kind of focus groups and groups of people involved in taking care of women and men with HIV to help inform policy at the Department of Health. We want to create places and ways for women to engage in care that meet their needs. So co-located services, pharmacy, counseling, OB-GYN, primary care, all in one place if possible, childcare available, extended hours. Perhaps women don't actually need to go to the clinic every 3 months and get labs. Maybe you could do telemedicine for the visits. And then encourage you to support groups, particularly BABES here in Seattle, providing education, advocacy, and counseling for women with HIV. A study earlier this year of women in England with HIV said that they felt like they had survivor conflict, not survivor guilt, but survivor conflict. They also said, we have no defined community. We don't have the gay community that HIV-infected men have. I encourage you to offer respect, empathy, and acceptance of your women and men with HIV. And when I have students or residents working with me, I encourage them to touch their patient. Touch can be healing. It shows that you see this person as a person, not someone with HIV that needs to be avoided in some way. You can do a physical exam, shake hands. I frequently hug my patients. I ask them if they want to hug. Touch is important. And then finally, encourage you to convey your joy in caring for people with HIV to not only your patients, but the students you work with, residents, and your colleagues. So thank you, and today is National HIV and Aging Awareness Day. Didn't realize that until I started doing my research. So thank you very much for your attention. I appreciate your letting me talk.
Very comprehensive. What are your strategies in your practice for engaging women that may have some of these barriers to
So the question is, what do I do in my practice to try to engage women who may have some of these barriers to care? In one way, we have a bit of an advantage because we are practice integrating HIV care into primary care. So women with HIV who come to their appointments are feel like they're in a group of people who may or may not have HIV, as opposed to going to a clinic in which everyone has HIV. So that tends to be sometimes a reason why women will come and may want to be part of a primary care clinic. So that's been helpful. Because many of my women have not disclosed to very many people, I tend to, if they've missed an appointment, try to reach out to them myself by phone or however other way they want to be contacted, but from me, not from someone else in the practice that they may not be familiar with, may not pay attention to their call or whatever. I confess I give patients my cell phone number. It's not generally abused in any way by patients, but if I do have a female patient with an urgent problem and may have a bit of a problem communicating in English, it's very difficult for them to work through the telephone system to try to get to someone who can give them the answer they're looking for, someone that actually knows them as a person and their illness rather than as a name and a member number. So those are a few of the things I do. I'm not sure what other things you might do. Counseling on site is nice to have. We don't always have that at Kaiser. Yes, Matt?
Yeah, great talk. I was wondering if you wanted to comment on how we should be using PrEP, and this has been a tough problem because overall incidence in women is relatively low, and so finding the right population for use.
Right. So Dr. Golden is asking about using PrEP in women and choosing the right women to use it in. And it's certainly a good question. There may be very obvious women with multiple partners, bisexual partners, commercial sex workers, where the answer is much clearer. And then there are women in which the answer is not as clear. Maybe two groups. So women who are negative with an HIV positive partner who want to become pregnant. I will have a long discussion with them about the risks of taking Truvada versus the benefit of preventing HIV. In general, I say, I don't think it's the risk, worth the risk, because the risk of transmission from your positive partner is so small if that partner is undetectable. However, in that group, as well as other women who may not yet believe U equal U and have a heightened level of anxiety, as you know, there are men that way as well. They will want Truvada for PrEP, and I will prescribe it for them. But continue to have the discussion about, is this really necessary? Do you really have ongoing risks that warrant taking this medication to prevent HIV? So that's kind of my thought process around it. Well, it's close to 9, and I haven't heard if there are any questions from the listeners. Nope. All right. Well, thank you so much for your attention. I appreciate it.